This video demonstrates a left optic nerve decompression in the setting of hyperostosis secondary to vitamin A deficiency. Here we can see a hyperostotic bone that is completely encasing both optic canals. The decision is made to perform a left optic nerve decompression initially. The concha bullosa is reduced and access is created by performing left endoscopic sinus surgery to expose the lamina papyracea, skull base, and sphenoid sinus. A sphenoidotomy is performed, and here we can see the sphenoid sinus is under-pneumatized due to the young age of the patient. On the contralateral side, access is achieved by resecting the middle turbinate and again performing a right sphenoidotomy. Once this has been performed, a rescue flap can be achieved on both sides with monopolar diathermy. The voma is delineated, and once delineated, it is removed in order to create binaural access for the suction and the instruments. The septectomy has been performed, and we are now going to drill out the body of the sphenoid sinus in order to expose the optic canal. By identifying the lamina papyracea early, we have our lateral landmark, and this can be followed posteriorly and superiorly to the skull base and to just anterior to the carotid artery. This is performed with a high-speed diamond burr, typically 3 mm in diameter. Once the body of the sphenoid has been drilled out, and we identify the posterior limit, which in this case is the carotid artery, that can be confirmed with image guidance and Doppler sonography. The rest of the procedure can be completed. We then drill in the direction of the optic canal, again using a diamond burr. The bone thickness is palpated until it is thin enough that it can be curetted off. Just anterior to the optic tubercle, the lamina papyracea can be removed using a Freer elevator. Here we can see that the bone of the optic tubercle is still very thick, as it typically is due to the coalescence of the lamina, the skull base, and the body of the sphenoid. This can further be thinned down until it is soft enough to be curetted off with a house curette. Must be exerted when removing this bone so as not to have any pressure on the optic sheath. The curettage continues posteriorly until the posterior limit is reached, and this can be again confirmed with image guidance. 180 degrees decompression has been achieved in this case.